Recording in progress.
السلام عليكم. السلام عليكم ورحمة الله. الحمد لله الذي علم بالقلم علم الإنسان ما لم يعلم. الصلاة والسلام على خير معلم الناس خير محمد. Welcome all and thank you very much for being with us today in the Gloma care. Is there any question or any concern? Anyone would like to or have any question or any points looking to have it? طيب الله يعطيكم العافية يا ربي. Thank you very much for being here. Let's revise our theoretical framework that guide us in this diploma. Here we are talking about a set of knowledge a set of knowledge, and based on this knowledge we will be able to develop the required skills, and then we will finish in the competency. And the competency here in this means that we will be able to deal with a different set of situations and taking a part from the comprehensive required care. We are still in the building the knowledge based. In the last modules, we know about the stoma in general, what that means, the term of stoma, and then we go for the history of the stoma and what are the key milestones or the cornerstones for this development. Then after that, we orient ourselves on the different type of colostomy and urostomy. And apart from the continuity of this, we will go today for the urostomy. From its name, we are talking about something that affects the urine in comparing to the previous part that affect the fecals or the stool from the GI. So here we will build on what did we take in the urinary, or there will be a need for overlap the steps and take the urine out before reaching the normal pathway procedure, but in simplicity, in the simple way, we are talking about the stoma that will allow the urine to go out from the body in a different than the normal way. Here, let's go for the definition. So by the definition, the urostomy, we are talking about a kind of procedure, surgical procedure, that creates a new way for the urine to exit the body when the bladder is diseased, injured, or not functioning correctly. And this is apart from the indication. This meaning creating the open, which is the stoma here, or what we refer it as the stoma. What the urostomy impacts? When we come here to describe this, we should come to the main components about this term of urostomy. We know about the urinary diversion, which refer here for the revising or changing the natural pathway, which is passed from the bladder to urethra, and we need the open that will contact or the point that the urine will get out, and it's done surgically, usually on the right side, but now we will discover it based on the types of the procedure and the indications, so there are maybe some differentiations, and we will know more about our rules as a people working in stoma care, what we will deal with this patient or those patients, and how we will end with the proper care. This is the most common type of the urostomy. We call it ileal conduct. It's the most common type, as we say. And in simplicity, during the surgery, they will take a small section from the small intestine, the ileum, and they will adopt this small intestine part, the ileum part, to be the pathway of the urine to get out. In these procedures, they are either connecting the tubes of the urine, as we will see, or they will make a pouch or a storing point for the urine before getting out. So we will explain it now, but this is in simplicity how it's coming on. And when we come to the stoma, so we should have a bed collection pouch, which is the urostomy bag. Either one piece or two piece systems, it depends, and it will be special for taking or keeping the urine in this pouch until the patient will be able to manage it in the proper way. Let's here revise. I hope if the sound is not here, please tell me. So let's see here and a simple introduction about this topic. الصوت مسموع شباب صبايا؟
دكتور مسموع تمام ممتاز.
تمام.
Urostomy. If you're going to have an ostomy because of a problem with your urinary system, it's helpful to first understand how the urinary system normally works. Your urinary system is made up of the kidneys, ureters, bladder, and urethra. The kidneys make urine by filtering water and waste products from your bloodstream. The urine drains from the kidneys through the ureters and empties into the bladder, where it is stored. Then urine is expelled when it passes from the bladder through the urethra. What is a urostomy? A urostomy is an operation that reroutes urine to a new opening called a stoma on the surface of the abdomen. The surgeon first removes a small section of the ileum, or small intestine. The intestines are reconnected so that they function normally. The surgeon uses the small section that was removed to make a detour for urine called an ileal conduit. One end of the piece is sewn closed. The other end is brought to the surface of the abdomen to form the stoma, where urine will exit. The ureters are then removed from the bladder and attached to the conduit so that urine flows from the kidneys through the ureters, out of the ileal stoma, and into an external pouch. Urostomy output. Urine will start flowing into your ostomy pouch right after the operation. It may be pink or red for a few days before returning to the normal yellow color. You may also see some mucus in your urine.
And as we said, this is one type of the stoma. Let's see also this.
Urostomy. Pouching systems. You won't be able to feel or control urine as it leaves your body through the stoma. So you will need to wear an ostomy pouch system or ostomy appliance at all times. The pouching system sticks or adheres to the skin around the stoma. The pouch collects urine, contains the odor, and protects the skin around the stoma. Urine on the stoma will not cause any problems, but urine on the surrounding skin can cause the skin to get red and break down. Ostomy pouching systems are lightweight and lie flat against the body and can be worn inside your underwear. Pouching systems come in different sizes and styles. Your doctor or nurse certified in ostomy care can help you choose which one is best for you. Most people try several types of pouches before they choose one permanently. Now, let's talk about the different types of systems. One-piece systems. A system can have one or two pieces. In a one-piece system, the pouch and skin barrier are attached together. Two-piece systems. In a two-piece system, there is a skin barrier, also called a wafer, and a separate attachable pouch. The skin barrier adheres to and protects the skin around the stoma and gives you a place to attach the pouch. The skin barrier usually includes a flange or rim to seal the pouch to the skin barrier. Flange sizes are made to fit exactly to a specific pouch. Drainable pouch. Drainable or open pouches have an opening at the bottom to drain the urine. They are closed with a fold-up nozzle or a tap. You don't need to remove a drainable pouch to empty it, so it can remain in place for several days. Drainable pouches are easy to empty and an option for people with ostomies that need to be emptied several times a day. Pouch closures. There are a number of different closure methods for open-ended pouches. All urostomy pouches are drainable and have a special valve that prevents the urine from backing up around the stoma. The drain can be a tap that turns to open or close, or a drainage nozzle that has a plug or bends up into its holder. A tap on a pouch will have a small marking that tells you whether it is open or closed. All drainable urostomy pouches can be attached with a larger drainage bag to keep the pouch empty while you are sleeping. See your booklet for full instructions on daily care and nighttime drainage.
And the issues for the pouch system, inshallah, we will have a special lecture for it, but this is as a part from orienting yourself about the specialties related to the urostomy comparing to the colostomy. Let's see for the last clip.
Here we can see an image of your urinary system. Here are your kidneys. Here are your ureters. Here is your bladder. Here is your urethra. Here is your digestive system. You can see here how the urinary and digestive systems are anatomically positioned. A section of your small bowel, ileum, will be cut out, along with its blood supply, and used to create a reservoir. The remainder of your small bowel will be rejoined. It is this reservoir, known as an ileal conduit, through which your urine will eventually flow. The surgeon will then connect the ureters into the removed piece of small bowel. This section of small bowel will now be used to create the stoma. The surgeon will then remove your bladder. Your stoma care nurse will be able to discuss the operation and care of your stoma with you in far more detail.
So now this is clear for us that this is the way or the procedure or the ways how it's already conducted. They will reconnect again. And apart from the famous or the most common, this is what did we see in the last video. Why this done? What are the reasons that make the patient a need for urostomy? Mainly, or can be continency in some cases, congenital as apart from at birth, spinal cord injuries that affect the bladder function. Now let's come here for the categorization. We discussed that this is the common procedure, but when we wanted to classify the urostomy, are they all the same or there is differences or different types? In fact, yes. There we can categorize the urostomy type based on how it's already performed, how the surgery performed, and it's already affected by the indication for opening the urostomy. The studies or the evidence about it classify it to two main types. We have either what they call it incontinent urinary diversion, or urine drains continuously. That's why they call it incontinent. Or continent urinary diversion, when they will create a semi-tight of or do the same function of the bladder, so the urine will get time to be in and no need for continuous drainage. Now for the incontinent urinary diversion, this is the ileal conduct. This is what discussed in the last clip, and this is the most common. There are ureterocontinuostomy, and for the continent urinary diversions, now we're talking about 5 types as we will come. Let's come here for the first type, incontinent urinary diversion, and how they will perform the ileal conduct. This is what already presented in the video. They will take a segment from the small intestine, from the ileum, and they will reconnect again the intestine, and they will use this piece as the stoma. Why they are doing this? The characteristic of urethra, this is the first one, it will not be suitable to be an open because of the size. The second one, already the surgeon get trained during the history of development of colostomy to make the part from the ileum outside. The third one, the patient able or the main function of the digestive will not be affected in a small piece of the small intestine to be isolated and taken out from the digestive system. At the end, they will connect the urinary tract or the ureterus tube for both from the both kidney to the ileum, and then they will take this to be in a drainage outside. So in this case, they keep the vascularization because directly the collateral vascularity will come for this small intestine or the piece they take it, and at the same time it will be used to and able to deal with these changes. Some patients they need more or to take care regarding to the issues of the changes in the characteristic of the urine to not affect the small pieces already taken, and then they will take it from or take it out from the abdominal wall to call it the urostomy. In this type of surgery, what are the ways or what are the characteristic or the main feature of this surgery? We will have urine flows continuously from the stoma into external bag, so the patient doesn't have any control, and there is no valve that will minimize the flow of urine. It's considered the most simple procedure, and this is the most common type of urinary diversion, and it's relatively straightforward surgical techniques and with the lower risk than other types of surgery comparing to the different types of the procedure. So it's straightforward. Take this ileum, connect the urinary tract, take it out, make the suture, and that's it. So this is the ways. Usually, this is done for patients who already passed through the cystectomy, so there is no bladder. They remove the bladder, either related to trauma, injury, as we said, or bladder cancer. So it will end up with no other ways for the urine to take out rather than the simplicity. So this is the most simple, straightforward, most common, with lower level of complication. That doesn't mean there is no complications, but with the prevalence rate and the incident rate less than the other types, as we will discuss. But it had some challenges for the patient, as they will be in need to use to have urine drains continuously. So the quality of life aspects of the patient, the management, our responsibilities, and of course there are additional issues related to the skin around the stoma because of the continuously urine getting out. The second type or the second procedure, it's called urostomy, and in this case, instead of taking part from the ileum, they will take either the both ureterus or one of them out from the abdominal wall. So they will not use any piece of the intestine. In this case, if we are thinking now, this can be much more straightforward, the same what we did in the gastrointestinal system. We take part from the gastro, which is either colostomy or urostomy, and take it out. So in the same way, no need to bring a help from another system or a different organ. But there are also different set of challenges that can face this patient. Part one, it's related to the characteristic of the ureterus that will get out, the size, the ability of the stoma in this case to deal with the external environment, the expectations or the possibilities that they will have in a complication still getting higher. So this is examples of urostomy. They instead of making any ileum, they will take the ureter outside. It either can be two stoma, in this case the patient will have. So in this case, he or she will need for two bags, just to be clear. Or in some kinds, they connect both on the same open. So either they will collect them or merge them before the open, or even when you see the patient, you will see the two opens inside, each one refer for kidney or from different ureters. So this is the second procedure. Anyway, I will leave for you this. I will share with you this video on the WhatsApp group. I think it takes time now until it works, but it will show you in the operation room how they open it, how they do it, and this is in simple how it's already conducted in the operation. They will open the opening from the abdominal wall, and they will take. You will see it in the video. They will take the uterus, utera, and even make it out for the stoma. From our common understanding, the complications here also will be in a different, and the patient in this case in risk for more complications than the previous time. It's less common, that's why this is make it less common to be conducted. It may be used in situation. So why they will do in this way? Why they will go for the hard way? This is the kidney, and this is the kidney, and then we will have the flow of urine, and in the iliac conduct they will put it apart from the small intestine. In this case, let's ask, what if this is not an option, or this is not option? Because either the patient have any problems related to the GI or ileal conduct, they have fried patients, can be less extensive procedure, maybe they have kind of disease in the intestine also, so they cannot rely on the ability of ileum to conduct this. So this is the characteristic, there is no other option, so they will take the risk and take it in this case. Ureterocontinuous, it's used in the advanced bladder cancer and usually with the metastasis condition. So the GI in many cases already involved, so they cannot use or they cannot rely on the ileum. Severe general conditions, and it's extensive surgery, and it's needed a special skills. Now in the NHS, they have a special competency or a privilege for urology to do this procedure because it's risky, as you will see in the attached video. Now, for our responsibilities. Now we are talking about incontinent urinary diversion. Okay, so we're talking about two types, ileal conduct or ureterocontinuostomy. So these are the only two types or two set of procedures under the type 1, which is incontinent urinary diversion. So from my perspectives, what should I take care of? My role as an stoma healthcare providers, and what are my limitations and points that I should check on. We're talking about continuous drainage of urinary into an external pouch. So this is the primary characteristics that I'm looking for. The urine is continuously drained from this opening. I can summarize our responsibilities in the following points. Preoperative counseling and education. So the patient should be oriented about the expectations. What are the needs of or the health-seeking behaviors that the patient will need? Because this is a lifelong, it takes long time. So the patient will use to have all aspects in his life to be modified. In our culture, in our region, the patients usually ask about salah, about being bathing. So this is all condition we should have answers about it and prepare the patient. Now, في أحد عنده سؤال؟ عايشة؟ مين عنده سؤال؟ سامع أحد فتح المايك.
الو الدرجيش مش المعتن.
تفضلي.
اللي مع المفتاح.
عايشة عندك سؤال؟ أوكي. طيب إذا في أحد عنده سؤال, if there is any question, please feel free to ask and we will have an interaction. طيب. The other issues is the immediate post-operative care in both cases, because the patients will come, mainly the characteristic urine will be changed. The patient still in risk for infections and the complication around the skin. The patient will need to be trained in self-care training and be able to know exactly when he will ask for the help. So define the complications or expected complication and the psychological support. So what we can do on the pre-education, now this is apart from the stoma nurse competency, as we discussed in the training program. So as part in this competency, the stoma nurse will be responsible to do this education in front of evaluator and evaluate the patient responses. So what are the things that the stoma nurse should figure it out in these cases? Anxieties, fear, concerns about the body image and lifestyle adjustment. So this is the point. We should address its presence and make a solution. Usually there are forms, and based on that, we should evaluate the level of anxieties, the level of fear, and the level of concerns, and we will have an intervention based on each one. Education on the procedure, so in simple way, no need for taking all the complexities of the operation room and the preparations, but we should explain for the patients the specific urostomy, the procedures, the responsibilities, how many, the type of external collection systems. Also, the second responsibility regarding to the counseling and education is the stoma site marking. And here there are trick points. In the colostomy or ileostomy, the space that we have it for movement are much, or the area that can the stoma to be applied in, bigger or give us more space compared to urostomy. Urostomy is also important to take care in a situation that is suitable for the patient. And as you know, we should check for the patient in sitting, standing, lying down, and we can apply, usually we apply in a bag, empty bag, and then ask the patient to do all these movements, and then we check the IDs or the places. But in urostomy, the space that given to us are limited to the middle part of the abdomen, middle to the left or right, but it's in the middle, not in the like in the colostomy. We have more space to get the site marking. The stoma nurse should aware about this point, because during the surgery they cannot stretch out the ureters for more than a limited time, limited space, so they need the flexibilities to be still in. In this case, they will be able to keep or prevent any trauma or complication that can be after the surgery. So this is important. Also avoid the polyprominences, the kind especially near the pelvic. Prevent places with the skin floats. It's the same in the colostomy. The skin floats that mean complications more, skin injuries more, and so on. If the patient conducted previous surgery, so we should avoid from any scarring that happened on this area. And this is all at the end. We think to prevent the leaks and skin complications. So this is what I should put in my mind when I'm looking for this one. Why it's important in the incontinence urostomy? We're talking about continuous urine. So this area will be in higher risk for getting irritation, mainly the skin around the stomach, and also the acid nature of urine, which can make like a kind of acidity injury to the skin around the stomach. And number 4 is the temperature of the urine. So the skin around the stomach will be in risk of all these issues. Again, it's apart from our responsibility to introduction for the equipment. So the doctors will.
عبد الكريم السلام عليكم.
السلام ورحمة الله.
أنا صراحة عندي إضافة بالنسبة لجزئية الستوما سايت إذا في إمكانية بس من فضلك. أنا صراحة بس بشارك الزملاء والزميلات من خلال خبرتي في المجال بالنسبة للستوما سايت، بس بختصرها في دقيقة. احنا أهم حاجة عندنا إنه ليش بنحدد الستوما سايت عشان موضوع اللي هو الهرنيا والبرولابس. صحيح. لأنه مشاكلنا إن البور سايت تأثر على موضوع الكواليتي أوف ذا بيشنت البوست أوبراتيف. فمهم جدا إننا نركز على هذا الموضوع خصوصا الستوما نيرسز، لأنه مع الأسف بعض الدكتورز بيضعوها في مكان غير مناسب، فيظل البيشنت موجود عندك في العيادة إلى أن يسكنها. فمهم جدا، ممكن النقطة هذه ما ذكرت في الستوما سايت اللي هي ريكتس مصر. الركتس ماسل هذه مهم جدا نعرف كيف نحددها صح عشان نقدر نحافظ على الاستوما من موضوع اللي هو التدلي او موضوع الهرنيا. لانه الركتس ماسل تعتبر اقوى مصل في الجسم سبحان الله، فهي اللي حتمسك لنا الاستوما اثناء العمل الجراحي. ومهم جدا ايضا اذا البيشنت يقدر يجلس على طرف السرير عشان نحدد الفولدد واللي هي الكرايسيس، لانه هذه برضه جدا مهمه في الكواليتي اوف الاستوما تبع البيشنت. شكرا لك.
الله يعطيك العافيه. لا بالعكس والله شكرا جزيلا. Thank you very much. Thank you very much. يعني she already tried to summarize for us the issues regarding to the site marking. وانا بحكي لك هاي ان شاء الله هذه يعني هيكون لها سبيشال ليكتشر في الكومبليكيشنز. Thank you very much. This is really an important point regarding to the site marking in the colostomy and urostomy or ileostomy, so any type of the stoma. The place where already the open will be on it had so much effect or different kind of effects on the patients' families, healthcare providers, and of course the quality of life of the patient. So thank you very much, Haya, and appreciate it. And let's continue here for our rules regarding to the stoma, introduction to the equipment. So apart from our responsibilities that the patients will show the samples of your urostomy pouch, accessories explaining their function, and also the dietary and fluid advices regarding to the what are the kind of fluids that should be taken and how they can detect the infection sign and symptoms. Directly on the first day after the surgery, so what are the responsibilities of the stoma nurse? And again, I'm talking about the incontinent urostomy, so the first type, because we will build on the type 2. We're talking about immediate post-operative care. For the day one after the surgery, we should check the stoma, pre-stomal skin assessments, daily monitoring, color, size, and complications. What are the expected complications? Swelling, retraction, prolapse, and signs of ischemia. And this is important checklist that to follow on and to determine when we will define each one. So the swelling definitions different than retraction, prolapse, and ischemia, and this will be apart from the complications. Assessing the pre-stomal skin for irritation, redness, and breakdown, and this is important responsibilities for us to make sure this will not happen. The pouching system application and management, initial application for the urostomy, appropriate teaching the patient how they will deal, and make sure the patient will not discharge from the hospital until we will have the proper dealing with the stoma, or as this family support, we will have evidence of leak-proof seals, and there is no stoma, skin stoma injury. Another responsibilities in the post-operative period is the urine output. So the patient should track the urinary volume, characteristic, mainly the color, clarity, odor, and the presence of the mucus. Usually in the urostomy, the patient will have blood, sometimes mucus, mainly at the first days after the application. So the patient, we should make sure that this is not a sign of complications. So bleeding in the day 0, day 1, it's accepted, but this should be start to be reduced gradually. The current guidelines to make sure or make it apart from the discharge criteria for the patient post-op, that the color, the suspicions for blood is less than 10% of the urine, or percentage of hematuria or blood in the urine. Pain management, the patient will be needed to ensure adequate pain control, and early mobilization will help to prevent the infection as ongoing education and self-training, and this is apart from the follow-up that we will have it, and usually this will be apart from the home health care or outpatient healthcare. So no need for the patient to come to the admission, and if there is no any complication, usually now they prefer to have forms of follow-up, so they will make sure the patients are managing and getting the bag and following up this in the proper way. Pre-stomal skin, this is also a key point. Now, in the current time, you have advances in the skin barrier, powders, integrate, There are powders and cream differs in the colostomy than the urostomy because, as we said, the nature of urine different than the nature of stool. So the nature of incontinence dermatitis that will come on the very wound area. Anyway, what we need here in a barrier cream or barrier powders that able to prevent or provide comfort zone for the skin around the stomach. Regarding to the other leakage management and night drainage system, as you see in the video, in the night, but the urine still is working. The kidney is working 24 hours. So there is a drainage system in the incontinent urostomy that used by connecting the urostomy bag to empty drainage system. And this will be during night, so it will give it a time for the patient to sleep. But it takes time from the patients until they will use to sleep while it's already connected in this way. And also the product selection. One of the challenges that faced the urostomy in comparing to the colostomy or urostomy regarding to the product selections, internationally, the amount of productions for the colostomy and urostomy more than the urostomy. So this makes in some institutions a kind of shortages. So our responsibility is to make sure that we are already able to provide the requirements for the patient. The needs is differing between the colostomy and urostomy, and also it takes individual needs, the individual preferences for which type, and with the differences in the one piece or two pieces system. So the supply management, it's also apart from the challenges that we should work on, the type of insurance, and so on. Dietary and fluid consideration, because here what's important for us in urostomy, hydration, and the type of foods that will make sure they will not have any impact on the constipations or any impact on the abdomen, so this can be affected. Also, the hydration to prevent or make sure that is no infection. Apart from the types of the urostomy, which is more frequent, first, stomal stenosis or narrowing, retraction, prolapse, hernia, or bleeding, as I already discussed. This is apart from the complications. So our responsibility is here that we will be able to recognize it when initially appears and also teach the patient how they will or when they should seek the help from the healthcare providers. And in urostomy, the complication prevalence rate higher than the colostomy or urostomy, and also the same for the peristomal infection. Apart from the complication can happen from these two parts, it's urinary tract infection. Urinary tract infection, the kind of urinary system difference and easy to penetrate the infection. There are also some reported complication, metabolic issues, and this is need monitoring for the education the patient for the electrolyte imbalance. It's less common with the ileal conduct rather than the urocystectomy. Anyway, still this need to be in a follow-up. So it's apart from the sinus symptoms that will come mainly with the sodium-potassium imbalance, and apart from the routine checkup for the patients to detect any problems that can happen for the patient if this happens. Psychological and support rehabilitation, as you know, body image, self-esteem, lifestyle integration, and the quality of life. So all this should be taken into consideration and in any stoma, not necessarily on your story, but this is apart from our responsibilities. Support group, family caregiver, so this is supportive and additive. Until now, we discussed the incontinence urinary diversion. So what already start now the evidence to support or take this in consideration for the second time, which is continent urinary diversion. Or, in quotation, we can say a kind of a procedure that will keep the urine stored internally so the patient will get a chance or the lifestyle will be a little bit different than keeping the bag open. These techniques involve creating an internal reserve or pouching system inside the patient's body from the segments of bowel to store the urine. So we will take apart from the GI again, and we will make something similar to the bladder, but the storage system, similar to the bladder, and then we give the chance for the patient to empty this in intervals instead of keep the bag all the time. usually by inserting catheter to the stoma and then avoid watering the bags all the time. So this is how it looks like. It's the same ways of procedure, but here instead of they will take only one piece of ileum to get it out from the stoma, what if they take little larger amount of the bowel or the small intestine and reconnect it again to be in a shape of the bag, and then connect the uterus on, and then the stoma will be here. So there will be a space for the patient to collect the urine. So no need to wear the bag all the time. So this is how they make this kinds of the stoma. This is the pouch system. This is the uterus. This is the kidney, and then the catheter will be open. And there are different types of catheter or valve that will be used in this situation. So it will give a chance for the patient to keep better quality of life. Or this is how they already connect. I will connect for you also this YouTube clip so you can see how it's already created. Let's come back here for the types. We have Indiana pouch, we have cock pouch, so different techniques. And in general, it takes a segment of intestine, often part from the large intestine or a small intestine. So it's a bowel. Either they take it from the colon, from the ileum. It depends on other factors. This is related to the surgeon decision and the patient. But they will take a part from the intestine, and they will create internal pouch within the abdomen. So they will reconnect again this bowel to be like in a bladder and store the urine. The ureters are connected to this pouch and small channel, or what they call it nipple valve. And this nipple valve will be a ways of taking out the urine from the internal pouch to outside. Is made from another section of the bowel, and this is brought to the abdominal wall from the flat stoma, often near to the belly button. And this is valve prevents urine from leaking. So they will part from taking in this way. Here, let's go for as we said, we have different techniques. The main characteristic for this one, that it will give the patient a chance for not keeping the bag, but he will be or she will be in need for 4 to 6 times to empty the drain. And this is make offers for dissections and freedom from external bag, as you see. So they give better quality of life. Usually, this is a patient's preference who desire to avoid an external bag, and they are able and motivated to perform self-catheterization in these frequencies, require good manual dextrose and cognitive function. So the patient will pass through cognitive function for the patients who complain from geriatric or Alzheimer's. It's not preferable. Usually this is done for the adult, and they will pass through this one. Now we will take about our differentiate between little parts, the types of the surgery. We discuss about Indiana and cock pouch. We have also other type. They call it orthotopic neobladder, which is like making the new bladder or neobladder. It's segments from the small intestine to create the bladder-like pouch, which is often connected to the urethra. So if they take it from the small intestine, so they call it orthotopic neobladder or a bladder substitute. This is close to the normal urination, so the patient will be getting much more comfort. The patient learn how to use the abdominal muscles and pelvic floor to push air out. So the difference is that when they create this new bladder or neobladder, there is no muscles like the same on the bladder to make it empty. So the patient will be trained how they will use the abdominal muscles to push and make sure the internal bladder or the pouch already getting empty. So it takes time from the patient until they will learn to use it in the same technique. Some patients still need self-catheterization at night. So this is apart from the complications or the discomfort type. In the incontinence urine diversion, we should have this device for keep the empty of the urine. But in this case, the patient need to wake up from the sleep, usually after 3 to 4 hours. Now we will see the studies, and to go to the bathroom and make the empty of the new bladder. Usually, it's done for a good candidate, as they call it. So it's healthy urethra good kidney function, able to manage, and cognitive-wise, they're already adaptable and tolerable. Strongly desire to maintain normal voiding patterns without stoma on the abdomen. And this is the main characteristic, as we say, it takes from the small intestine, and there is no need for bag or pace, so they will not be need for the same, or they will not face the same complication like in the incontinent urinary, but they will have different challenges also. What our responsibilities in this case? We will have more responsibilities in teaching complex self-management techniques. So this is not an easy procedure for what the patient will be in need to do it for 4 to 6 times per day. Why? Because we have a valve and we should make this empty, and this procedure will be a risk for infection. So the complications also can be critical if the patient did not strictly follow the catheterization procedures and how it already will be done. The patient in need also to understand that this doesn't mean he will not in need for changes in the lifestyle. So this is the important differences between these types in the same way. So here, our responsibilities in the continent urinary will start from the beginning by what they call it rigorous assessment. At the beginning, with all kind of stoma, we make the patient's assessment, right? About the needs, the general health condition, the history, as we said about the site marking and so on. Here we will add something extra, what they call it the cognitive ability, because we should make sure the patients are able to deal with this manual dexterity, willingness to commit a rigorous self-catheterization. Because if they fail to maintain the infection control aspects, they will end by different kinds of complications. And also they should be in a little healthy enough to make sure that they will be able to use the pelvic floor exercise and the abdominal wall muscles to make sure the time voiding of using of empty of the bladder. Detailed explanation for the patient about the anatomy, function, how the system works. Usually it is done in the counseling appointment. It takes time to answer the patient's concern and so on. Again, we should make sure here for the stoma site marking in the continent continuous reservoirs that they have a different ways of looking for the site marking, adding to all the points that in the stoma, the same what Haya said about the side, the skin floods, and so on. Here we should check the ability of patient to make that catheterization in the situation of the abdomen. At the beginning, we focused about a suitable place on the patient's body and the patient's responsibilities to put the patient back. Here, the patient's responsibility is adding aspect more, which is the catheterization. So they will insert, I will share with you the video, they will insert the catheter inside this valve and they will make the empty of the urine according to that. So they should be trained about catheterization, the concepts of intermittent catheterization, the bowel preparation, and so on. So this is important. In day 1 after surgery, the patient will have a multiple tube post-op. So the patient will come with a tube on this urine. So they will not, the patient after the surgery, they will end up by a surgery, Redivac drain or the surgical tube, and that drain or catheter from this new pouch or new bladder. So we will make sure and monitor the output, patency, site marking, the complications, intake and output, and so on. Early education on the reservoir care, so initial instruction, gentle irrigation, maybe the patient needs, especially on the post-operative time. So the irrigation for this pouch or this new bladder, okay, well, this is important. The pain, this procedure much more painful because of the space that will be created in the abdomen comparing to the previous times. So we'll have the catheterization, so we need the education about it, hands-on, step-by-step instructions, sterility, and the intermittent catheterization. This is important. The importance that the patient should train on the hand hygiene, the insertion technique and the depth, because we don't want to make an injury inside the abdomen and end by additional complication. When the pouch is empty, so there are different techniques to make sure when the pouch, when they already inserted to be an empty, by either waiting until the time so there is no urine going out, and this is in a kind of while the patient's trying to push their own pelvic wall and abdominal muscles to make sure smoothly contractions to recognize when the pouch is empty. So this is important techniques. And now we have different systems and different kind of indicators that can help the patient in this determination. The frequency of catheterization, usually, initially it will be very frequent, then the patient will start to use their own routine. Usually it starts by 6 to 8 times per day and even at night. How they will make cleaning and storing for the reusable catheters if it's already suitable for that, because now we have a different types of catheters that can be used, and they start to suggest the reusable catheters while the infection still it's a complication. Pouch to flush out the mucus, because post-operatively they will have a mucus, and they will make sure there is no stone formation, infection, or blockage that can affect all these procedures. Again, as we said, the timed voiding, so it takes time until the patient used on it. It takes maybe 8 times per day. Some patients reach more than 8 times per day until they will use their own weight. There are also the Valsalva maneuver or Credis maneuver, which is a technique. They say, you know, the Valsalva maneuver, when they already try to make pushing on this place to increase the abdominal pressure and empty the new bladder, and this the patient should train on it and to not be directly adopted post-operatively because of the wounds and the pain that will come on, but the patient should be able to use this one. The pelvic floor muscles exercise, potential, as we said, the nighttime incontinence, so the patient should get out from the sleep. So usually at the beginning time, this is discomfort for the patient. They will sleep only 2 to 3 hours until they will be in need to get out and empty. Otherwise, the urine will kind of push the valve and take complications, and then we end by more affecting the quality of life for the patient. This is example of the orthotopic new bladder. So this is the new bladder that they make it in this way, and the stoma can be here, here, here. So it depends on the suitable patient situation. But as I said here, it will not be away from the 2 hands, because in this procedure, the patient will need to use the 2 hands. Anyway, this is taken from the Bladder Cancer Associations in Canada. Another technique, it's Indiana pouch, and Indiana pouch, different techniques than the orthopedic pouch, which already connected in one-piece system. Here, I'm not sure of the picture here, that they will have one collection for the bladder and another piece to make the urine flushed out. Indiana pouch, they take apart from the ileum also, but here they will make in the same parts and make the bladder and the pieces or the stoma from the same piece with continuous piece instead of taking in a different ways. Anyway, the patient usually in the week 1, they will be trained for the Indiana pouch for every 2 hours, start at night every 3 hours. Then the frequency start to reduce, so it can reach up to every 4 hours, and at night every 6 hours. And of course, it depends on the intake output or any other complication for the patient. Important here to know in the stoma, the Mitrofinov, which is this is the procedure of the valve or the techniques that will be used, how the valve already will be produced. So this is the Mitronov technique. They have a different kind of or surgery procedure for the new bladder. And here housed already the connecting channels or the opening for the stoma. And this is, they will protect in the Metinov, they will protect it in ways that will prevent the injuries during the catheterization. Anyway, this is all surgical techniques. Cutaneous urostomies. Here we have also then we finish the type 1, which is incontinence type. Then we have in type 2, we discussed now the Indiana pouch. We discussed the ortho topics, and we discussed the Mitunov techniques, which is all have the same principles. We will have internal new bladders, and they are differing in how the procedures can be conducted or how the stoma will be. But at the end, this is all supported in this way. We have within the part from the continence part was cutaneous urostomies. In this case, they open in the same techniques. They open the urotomies and they take it incontinence in this case. Here I try to summarize orthotopic new bladder. Now for us, because we're dealing with the patients more as a part from the post-operative care, so the differences, the exact differences or techniques of doing the surgery is not our focus, but important for us to know about this information because it affects on the complications. So in the orthotopic, Indiana or Mitunov, this is all continent type, so the patient will not need to use the bag. Here also the kind, and for temporal, in some cases for the orthotopic, it will be the placements of the stoma will be in suprapubic catheters, so it will be in a continuous, so that's why they put here, because they will keep the catheter to get outside, and in some cases also even for Mitunov surgery, in all cases, either with the stoma or with a continuous catheter, but the patient will have a valve or control over this catheter, so the patient can live without the bag. All at the end will have diversions, and just to focus about the complication. In the ileal conduct, this is the most type of the urostomies. So usually, or the main complication is the colostomial hernia, and this is much more common than the colostomy because of the frequency of the techniques used by the doctors. Because here we're talking about urologist, neurosurgeon, in comparing to the general surgeon that do it in the colostomy. So stoma, and the same for any stomal and peristomal complication, mainly the periswonal skill, and they can have an endostomatic structures or a closure can be happen in the duct itself, and still the patient at risk for UTI. While in the continent type, the patients may have incontinency mainly in the beginning time. It can extend up to 6 months. The patients need to deal with the incontinency, especially in the first period of time. The patient will have nocturnal incontinency at night until the patient will be used. The problem with the new bladder, the patient should use or learn that they will wake up at night, make this procedure, come back again. So, and at this time, the patient not necessarily to be in full conscious, so the complication can happen. And a lot of patients, they have problems at this time, mainly at the beginning. They will need also to do a proper or ongoing irrigation. A lot of patients after time, they forget to do the irrigation, then they will have with the stone formation in the new bladder. Don't forget that the kind of the new bladder, this procedures, it used the bowel, so it's not the same characteristic of bladder. So the expectations to have accumulations or complication can have a problem, and a stomach and the closure, and the same for the UTI. The Indiana pouch, which is similar to the orthopedic but a different surgical technique, so it will have the same or similar complications. In many cases, the reported cases said about the parastomal hernia are higher prevalence in the Indiana pouch compared to orthotopic because of how the surgery taking, and it takes time from them until they will make the pouch inside the abdomen, so they will make it bigger, and they take it from the same bowel, so this can affect on the kind of the abdominal wall around it to make the herniation and the stenosis. Now, Mitunov, the main problem is the stomal prolapse, and this is what we'll discuss in the complication more details, but this is for you because of the stomal leakage and the stomal stenosis. In the continuous urostomy, or when they directly open the ureters to appear outside, this is not recommended procedure because of the high complications. So skin breakdown, difficulties in the bulging, the complication, the peristomal, possibilities of getting closed, and the high chance of UTI. Our responsibilities should start at first by determining the type of urostomy. Are we talking about continence or incontinence? And this is need an attention for the kind of urine that the patient will get out, the kind of complication that associated with the different type of the procedures. Important for us also to put the patients on track regarding to the supply management, because each type they have their own different kind of needs, and also based on what are the hospital in need to birth case, for example, for 1 year, how much the expected amount of urostomy or catheters ordering, and also for the continuous urostomy, we should also include the syringes for irrigation. And now in Ministry of Health, they added as a part from the package. So when they will take the urostomy, they give him the syringe for irrigation in the continuous, and it's apart from the insurance for the severe patients. Detect the complication, again, the different complication or the different types as we discussed. So this is an important part, and the UTI, as we represent, this is still high risk to be developed during anyway, any urostomy in the patient is risk for UTI, but the prevalence of UTI increased with some cases, and this should be taken in consideration. The complications related to the mucus management, the patient will report this presence of the mucus in the continent diversion. This can lead to blockage or stoma formation, and it's apart from the nature of the mucus, because we take it from the bowel, and the bowel will produce mucus. So the patient should learn how to clean up this mucus in a frequent manner. Again, the needs for the metabolic acidosis, and the patients need to again focus on the electrolyte imbalance and the incontinence, mainly at the beginning or previous procedures. Even I remember some patients with a new bladder, they also were in need to use urostomy and urostomy base and back, even if they already passed through the new techniques. And this is important to add it in your mind, because in some cases the patient will be, even if they apply the different procedure type, in need for urostomy, that mainly at the beginning duration, until the patient used to have a suitable management, and the wounds will be healed internally, so the blood will reduce, and the blood duration or the time that the hematuria or the blood in urine take more time than the incontinence, because there are more than one wounds inside the new bladder itself, because they will make suturing for it internally. We should make sure about the underlying medical condition. So why the patient done for this one, the patient did not do the urostomy because they like to do it, but there are some underlying medical condition, and this underlying medical condition can affect on the management of urostomy. So the overall health of the patient should be taken into consideration, the medical condition, check for the patient's medication, any previous radiation therapy for the cancer patient, and revise each time the patient comes to your clinic for the stoma, revise all the kinds of medication, and make sure that each type of this medication is taken for a specific or purpose, and still this purpose exists. And our patients, when they come, they may be followed by 7 or 8 doctors, cardio, medicine, diabetes, endocrine. So they will come with a huge amount of medication. There is no one can revise all this medication except the stoma nurse in this case. The bowel health, it's important because we don't want additional complication, dexterity and the cognitive function, and this should be kept frequently assessed to make sure the patient skills still maintained in this case. Because if we have to get any doubt or confusion about the patient's skill in doing the MPT or irrigation, or the patient's medical condition deteriorations, So maybe the doctors will go to transfer to make this continence divergent to be incontinence divergent and remove this neobiology. The patients, now what are the factors that affect which choice, where we will go for? I will tell you from my experience. First is the patient preference or the lifestyle. So usually the patients choose either or, but in almost all the cases or in many cases, it's apart from the surgeon expertise. Not all doctors able to do these two types. There are doctors already specialized or more comfortable to do incontinence and other comfortable to do the continence, and even within the continence, some preferable to go for Indiana pouch or orthotic bladder instead of that. Anyway, overall, it's apart from our responsibilities for the stoma, for the urostomy. The focus, and this is unfortunately what happened in many hospitals, that the focus of the healthcare for the stoma issues more for colostomy and urostomy compared to urostomy, which can be why because of the number of patients. But the complications and the vulnerability of the patients with urostomy are higher. So we will stress on this one regarding to our responsibility as a comprehensive patient-centered care. Also, the patients need additional focus regarding to the physical, psychological, social issues and economic factors, the insurance types. The patients not need only for stoma bag and stoma base. They need, as we said, for irrigation, for syringe, for cleaning, and so on. Planning and develop individualized care plan based on the patient needs, the type of divergent, and the need for follow-up. Also, we need to make sure that the plan is already in the place. When we have more than one person specialized on the stoma services in a hospital, so all should have the same standardized way of working with these cases, so the continuous evaluating the effectiveness of the interventions and adjust the care plan based on the patient needs and the preferences. Also, our responsibility, as we said, that we are advocating the patient rights, the access to supply, the appropriate care. If you have doubt regarding to the insurance type, so it's better to transfer or refer the patient to another service. If there is a problem in the supply for this service or kind of service, so can be referred to another kind or another healthcare facilities. And then this is not on a one-man show. Stoma or making urostomy, it's not on a one-man show. So we cannot rely only on the surgeon or urologist or nurse. Rather, it's a comprehensive setup. So we need a cooperation from the surgeon, the anesthesiologist, the urologist, the pediatrician, and of course the stoma healthcare providers. Make sure that for the planning in the yearly budget for having the continuous supply for these patients, the community resources. A lot of patients, I saw them, they already open in a WhatsApp group or Facebook groups so they can share the extra supplies, making for themselves support groups. And I prefer, after the experience, to make the support group split between the colostomy and urostomy rather than the urostomy because of different needs. In many cases, when we start the idea of the support group, we started by making all the patients on the stoma together, but we discovered that there are differences in the preference and needs. So the patients in urostomy, they have different needs and they need special or different kind of services. Now with the expansion happening in the home healthcare services, so the urostomy is apart from the eligibility for the healthcare services for long-term care and things. Also, this is an virgin fields or fields with less expertise in the research and education. So I will prefer, when we come inshallah to the term paper, to make the urostomy part from your interest or research interest. Majorities of the stoma is focusing only on colostomy and urostomy. So what about the urostomy? So add this one in the research. We have a limited number of scientific evidence and academic evidence related to urostomy. There are a lot of fields campaigns suitable for research in this field: quality of life, management, support, self-image. This lack, and this is an opportunity to get published well research in Jordan or Gulf or Arabic region, etc. Here I share with you some latent evidence about this ideas for the research. This already, last published, I think it's published 2025. Yeah, there are 26, I think that's already published. It's a golden opportunity enhancing nursing education, and Varian Chaplin, it's well known in the Canadian associations for the ostomy nurses. And here they try to make what are the competencies required, and they stress the point that the competency of the studies that for the competency of stoma nurse get limited focus on the stoma. They here stress on what are the factors that the stoma should check on for the urinary diversion or urostomies, the body image. I will leave for your slides, then you can read and take the details, but what are the most important parts that we should train ourselves, train our colleagues about it, the body image, continency, and with the differentiations between continency and continence. Enhanced recovery after surgery or ERAS, and this is important. When we're able to take the patient out or discharge the patient from the hospital after surgery, that means we'll support the patient chance for proper recovery and prevent that complications. Funding and how we will evaluate the ability of the patient to sponsor the treatment, because this is a need and a long-term plan. In Jordan, we have different types of insurance, either governmental or private, and there are different ways to deal with this techniques, because if the patient will go for incontinency, so the urinary bag, it's a life-threatening issue. So this is important and it's critical in all stoma, but this also should be taken into consideration. The rehabilitations for the patient will use to have this technique, so we should check the ability of patient to use with this care. Preoperative stoma site marking, as we already discussed, and what also add from your comments and our colleagues about the stoma techniques. And this is, anyway, this will be discussed in more details in the future, but here there are adding aspects for the urostomy comparing to the other type of stoma. And of course, the sexual health and the ability of patients to have their own life. The techniques are the check for the post-operative education, the adequate flow intake, alteration in the bowel function, cleaning intermittent catheterization, pelvic floor exercise, voiding and navigation, and signs of urinary infection. In these techniques or in their own, in her point of view, as we say, this part from the competency. So we will have patient and we will have the nurse, and they will make an education, and we should have an evaluation system. Either someone else will see if the delivery of the information done in a proper way, and then the patient understand, and then they follow up the behavior of the patient later. And this is important module for the stoma, because if the patient will not follow up the proper protocol, then they will come back with a complication, and we will have more burden on the stoma nurses. So this is part from the competence. This is an example of the education scale that suggested in. Anyway, this is education scale. It's adopted many times, but it started or first created 2013 with, so it can show us what are the points that I should check the patient's ability and understand. So let's hear, for example, we'll come for the first scale, which is the reaction of the stoma. So I should evaluate the patient either to 0, 1, 2, so there will be 0. If the patient has an touched and stoma on the initiative nerve, so there will 2. If the patient has seen touched the stoma and his own initiative, and so on. Now we will come for the second point, which is the removing the stoma appearance. So I will give the chance for the patient and evaluate the patients based on the ability to remove the stoma appearance. If the patient's unable, so it will be 0. If the patient needs assistance, so it will be 1. If the patient needs verbal guidance, but skill or psychomotors able to do it, so it will be 2. If the patient do it full independently, so it will take 3. The stoma diameter, the same. If the nurse if the patients need help, need verbal communication, able to do it alone, adjust the size, the skin care, the same, fitting a new stoma and repeating the procedure. And this is important also regarding to the techniques of the urostomy. Now, at the end here, we will have a score. So the high score will be 21 and the lowest score will be 0. So the patients will range from score of 0 to 21. This is important not only for the insurance company, but even for now, because this is also added to the insurance company, where they would like to know if the nurse able to give the patients permission to discharge from the hospital or not. And also if the patients need for a frequent follow-up or not. It depends on the patient's conditions. And also to evaluate ourselves and our educational procedures. So this is in general for the urostomy. We already passed through the types of urostomy, what are the differences in the techniques, the procedures, and what are the important points that we should take it in consideration, what are the expected complications that can happen for the patient, and our roles and responsibilities. Allah يعطيكم العافية يا رب. Is there any question or concern? الله يعافيكم يا رب. أي سؤال أو استفسار؟ طيب سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. نستودعكم الله الذي لا تضيع ودائعه ونراكم إن شاء الله الأسبوع القادم. هذا الدكتور عبد الكريم يحييكم. Please take care of yourself. Be safe and stay with us. Thank you very much for being with us. Assalamu alaikum.
Recording stopped.